computer.
Right.
Move away. So this one here, I'm just going to pause every other slide and ask questions, which you will type the answers into chat to keep you awake, etc. So I'm going to talk about retinoblastoma and other pediatric eye tumours. I will not be covering the genetics of it. That is a separate topic. So I'm going to focus on pathology, macroscopic, microscopic, and other things like that. So here are our learning outcomes and the topics that I'm going to cover: why, what, how, histo, microscopic, staging, risk factors, mimics, and other things. These are ideal short answer question topics. If you think about it, you can make a question about each one of these things. And that's what you should come back to in the end. Okay, first into the chat. Why enucleate retinoblastoma globes? Type away. Give me more than one reason.
Save lives.
Yeah, but most of them these days are not enucleated. So what are the reasons these days? And with modern technology, you've got laser, you've got all those other things. Okay, so yeah, blind painfuls, yes.
Prognosis, failed to respond to treatment, risk of MIP.
Yeah, failed treatment, blind painful. Yeah, and you've tried everything else first because that's not the first line of treatment. We get that. So, all right. So here are some things. Did we cover all of these? High stage, refractory, aim for cure, no visual function. And I don't know about you, but sometimes in New Zealand, we get people from the Pacific Islands and they have no access to follow-up or other sorts of treatment that we would normally be able to give. Okay, so genetics, I will not cover the genetics. Okay, now one of your learning objectives in your curriculum is information to communicate to the laboratory. What information would you write on the pathology form for your pathologist? This is practicing short answer question type answers. Okay, which eye? I like that. The age, it's already on the sticker. Tell me something I don't know. Okay, presentation, previous treatment. Previous treatment, yes. Visual acuity, no, I don't care. Query RB gene mutation, yes, that's what we're going to find out. Whether any treatment is tried, yep. Family history, okay, you're getting the idea because these are important things. What do I want to know? I want to know which side it is. Diane, have you ever got the eye and you don't know, it hasn't been indicated which side it is?
So I have received globes where the clinical information is eye.
Yeah. Prior therapy is very important because usually it's a failed eye and I want to know what you've done beforehand because sometimes I can't see anything, there's nothing left, you've fried it. And the clinical stage, that helps me also in what I'm looking for. Anything else that you'd like, Diane?
So yeah, sometimes I quite like a description of where the tumor is in the globe because although illumination is useful, it's not perfect. So if they tell me whether it's, you know, anterior or posterior or whether it's right or left or superior or inferior, that's very helpful.
Yeah, give me the quadrant, that helps. Yeah, because it depends where, then how I'm going to cut it. So,
yeah, because we have to do a special little cut and we need to know where the tumor is.
Yeah, and I usually go then look at the MR, so to identify that. How to send the specimen. So this is another short answer question. How to send the specimen to the laboratory? Type. It's the covers all of those things in your okay, orientated. Yep, talk to the pathologist. Mark the site of tumor.
Yes, thank you.
Yeah. Yes, those are all good things. Now, there's one thing that people haven't mentioned yet. What do you put it in?
Fresh.
Fresh. Okay, yarn. Top marks. Yeah, yarn's got the best answer.
So we need melanomas fixed, don't we?
It depends on your lab, but we receive our melanomas fixed. So how to send it? Fresh and orientated. Those are the main things that I want. And here, the surgeon has marked the medial aspect or something. And I like to, you can write on the request form, you know, superior media quadrant. So next I'm going to talk to you about how we handle the retinoblastoma in the laboratory. So here I've cut it open. You can just peek onto the inside. It's fixed now. But first of all, what do? We take, and Andrews asks stuff about vitreous. We'll get to that, because the thing that I'm going to do first is I'm going to open the fresh globe and take out some tumor so that I can send it for genetic studies from the tumor. So I've got a video here. Harvesting fresh tumor from enucleated globes. I'll just mute that and talk over the top. Okay, this is how we do it in the laboratory. I gather all my equipment together, can of spray freeze, razor knife, and here I've got the fresh globe, and I've put green ink on the optic nerve margins so that we can identify it in subsequent sections. So, and then I'm going to take the optic nerve margin and I put it into this little plastic cassette and process that separately, because it's a surgical margin. This is what we do in our lab. We, to make the globe firm and easy to cut, I spray freeze it first. Then I'm going to use a razor knife, and I can open a little window or a calotte in the globe, and retinoblastoma has virtually no stroma. It's liquid. It's kind of like pus, so you can just suck it out and put it into a specimen container. I freeze that at -80 degrees. So 4 steps to harvesting fresh tissue from a enucleated globe. That's that. Back to my presentation. Here we go. Any questions? So the answer to Andrew's asking about vitreous. So I don't specifically remove the vitreous. When I cut that calotte, often the vitreous just flows out like this. And flow cytometry is used for lymphoma markers. Lymphoma is not the question here. So I don't do flow cytometry on retinoblastoma globes. So let's look at some pathology of globes. So here, can you see this? And there's tumor here in the anterior chamber, and the pupil is asymmetrical. And so when I open this up, I have to know to look in the anterior chamber to find the residual tumor, because there was no tumor in the posterior globe at all. This is the only residual part of tumor. And that's why I need to know it's been previously treated. And where is the tumor? Type in the chat. This is when I sectioned the globe. I found the tumor, but where is it? Can you see it? Where is that?
Yep.
Yeah.
The ciliary body.
It's between the plicae of the ciliary body. And there was no tumor anywhere else. Look here in the rest of the globe. Nothing. So clearly this had failed all previous therapies, and that's why it's been enucleated. Okay, our job as histopathologists is to stage the tumor, and we use the AJCC cancer staging manual. You can look that up online. And the staging criteria are the prognostic criteria that we have to bear in mind. So it's to do with the optic nerve, it's to do with the laminar cribosa, and it's to do with the choroid. So staging, just think S for staging, S for spread. So let's look at some different stages. Okay, so here we have a white reflex. And in this tumor here, this is filled the globe, but there was some choroid invasion. So that's a PT2, just a little gallery of collection. Oh, I remember this one here on the radiology. There was a lot of dirty fat in the orbit, and so there was a high suspicion that this had spread into the orbit. But actually no, on radiology, on pathology, it was confined to the globe, and there was a lot of inflammatory reaction around the outside in the orbit. So it wasn't a PT4, it was a PT2 confined to globe. Here's another staging factor, which is choroid, invasion of the choroid. So your eye is drawn by the tumor here in the posterior globe, but see this little dome shape here? This is underneath the retinal pigment epithelium. This is choroidal invasion. How big is massive? It's actually 3 millimeters. So if it's bigger than 3 millimeters, it's called massive. And no, you don't need to remember the TNM classification, but you do need to know the things that involves choroid and optic nerve. And the ICRB, I think that's a clinical classification system. But what you need to be able to identify and describe is the things on the pathology slide, because that's what you're going to be examined on. Okay, so I'm going to talk about other examples of different stages. Here. Right, type in, what do you see involved here? So we can see this little thin line here? That's the retinal pigment epithelium. So this has got massive choroidal invasion here, and there was some fluffy stuff in the anterior segment, so anterior chamber. So 2 poor prognostic factors. And notice we're looking at all these things and we haven't even used the microscope yet. So, and this here, if we turn this into a full mount slide, just look at that and that, this is the same one. Here we go. So this is a retinoblastoma and this is the massive choroidal invasion here. Also, you can see the iris has become strangely dark and the ciliary body. And so this is invasion of that retinoblastoma into these anterior segment structures. So 2 poor prognostic factors happening here. Whereas the optic nerve looks clear. So I'm looking anterior chamber, choroid, optic nerve. Anterior chamber, choroid, optic nerve from the front to the back. A, C, N. Just apply that to all your globes. Let's do the same here. So anterior chamber, not involved. Massive choroidal, yes. Optic nerve, yes. At the margin, yes. So PT4. So this is the highest stage that we can get on an enucleated specimen. What does this mean? Probably radiotherapy. So, histology report. So this is what I would write, some description of the type of tumor. Now, there's 3 other things that I'm going to comment on. Please type those into the box. What am I going to comment on? The staging factors. Start at the front. This is a bit of recall practice for you. The parts that are going to be involved. Optic nerve margin, yes. The structures involved, yes, and the choroid. So these are the things that are important in retinoblastomas. Anterior segment invasion, choroid invasion, optic nerve. Just start at the front. Anterior, choroid, optic nerve, and then of course scleral invasion. That's the whole outside part. So most of you have got that. Diane, do you count mitotic figures in retinoblastoma?
No, my count usually goes 1 to 1,000,000.
Yeah, they've got like gazillions, so I can't count more than 10, so I don't bother. So too hard. So it doesn't make any difference whatsoever. So you could, but I don't. So it doesn't make a difference, so therefore I don't. So anterior choroid nerve, however you want to remember that, like ACN, start at the front, work backwards. So it's different things that you have to comment on in a retinoblastoma compared to a melanoma. But, you know, it's not that hard. Just think about it anatomically. Right. Histologic risk factors for progression post-enucleation. What do you think? Type. Give me one thing each. Differentiation, optic nerve head extension. Yes, so optic nerve, yes. Vascular patterns, says Anna, differentiation, pleomorphic, mitotic. So for progression post-enucleation, margin's really important. All surgeons are concerned with margins. High risk factors. Okay, anterior segment involvement, post-laminar optic nerve, and massive choroidal invasion. Yeah, and Yeah, margin. I didn't put down margin, but you're absolutely right. So extraocular involvement, yes, although yes is the answer. And scleral invasion, yes, would also be a high risk factor. Yes, all of those are correct.
Nerve margin, Amanda.
The cut margin, if the tumor is at the cut margin.
The bit we inked. The
yes.
very tippy end.
The green part. Yes, the part you cut.
Oh, a question here. Is scleral invasion not a high risk factor?
Yes, it is. Yeah, I didn't put that here. Have you ever seen a scleral invasion, Diane?
In the retinoblastoma, no, they get out other ways.
Yeah, I've never seen one either because they're really soft and squishy. And sclera is really tough and hard to get through. So they do get out, but I've never seen one come through the sclera. They use natural channels.
Yeah, they kind of squeeze down the nerves and the vessels.
All right, what about this concept of tumor-associated lymphocytes? I don't know.
There's so much necrosis going on in them. That I don't remember ever reading a study on tumor-associated lymphocytes in retinoblastoma.
No, it's not a prognostic factor that I know that has any p-value attached to it. So whether they're present or absent. RB mimics, I'm sure that you know these three things that you can recite off easily. Yep, coats. Things that really cause leukocoria. And what's the next thing? Coats. Oh, this was a great case I had when I was at Westmead. Okay, so it was a nucleated, they knew it was most likely Coats because it was blind and painful. And you can see why. There's a funnel-shaped retinal detachment and this very glassy looking exudate in the posterior part of the globe. We hardly ever get Coats enucleations these days. Have you had one, Diane, recently?
No, I haven't. Not.
And it's so rare to have them for this. I sent this to Ralph Eagle and he said, yeah, okay. So, because they're so rare to enucleate for that. But this was blind and painful as well. Okay, so we've talked about retinoblastoma, which is a globe tumor. But since we're in the region of the orbit, type in what else can happen in the pediatric orbit that's a tumor. What could this be? Rhabdomyosarcoma, yes. Dermoids can happen there. Rhabdo's pretty popular. Yep. Tell me something that could be benign. So just mass. Yeah. LCH, yep. Hemangiomas, yes. Leiomyomas.
Not usually in kids.
Yeah, in adults it's possible. Eosinophilic granuloma, yep, which we call these days Langerhans cell histiocytosis.
Yeah,
and vascular things. Oh, good ideas. Excellent. Okay, so I will tell you on this radiology, this was not, it didn't have characteristics of a vascular lesion. It was a solid tumor and there was probably some necrosis in it. So, and it's solid. Okay, and this is, that was a rhabdomyosarcoma, which was your most popular malignant option. These are some other things. Nobody suggested metastatic neuroblastoma. Think children. So you've got to think children's diseases. Neuroblastoma is the most common extracranial solid tumor in children. And the orbit is a good place for them to metastasize to. So you're all thinking of Mets, you usually think of adults, you think of, you know, colon, breast, that sort of thing. Children, think metastatic neuroblastoma. You've heard of blueberry muffin babies. Well, that's one of the blueberries. And the types of vascular tumors that we see, or vascular lesions that we see in the orbit of children, are the specific type here called infantile hemangioma. And so I see several of you mention hemangioma. Usually they're not resected, but that's what. What do rhabdomyosarcomas look like? They look like small round blue cell tumors. So, yeah, small round blue cell tumors. If we go a little bit closer, we can see some of them show skeletal muscle differentiation. So these are looking like tadpole cells. They look like little tadpoles. They've got a head and a tail, and the tail is made up of eosinophilic material. Eosinophilic material is actually skeletal muscle fibers. It's trying to make sarcomeres, whereas this alveolar rhabdomyosarcoma is undifferentiated mesenchymal cells, and we call these small round blue cell tumors. This is when we need to use special stains to determine the line of differentiation. A common misconception is that rhabdomyosarcoma originates from skeletal muscle. So, you know, like the skeletal muscle of the extraocular muscles. Diane, do they originate from skeletal muscle of the extraocular muscles in the eye?
No, they don't. No, they come from stem cells. That's
right.
Differentiate.
So, it's a tumor, a primitive mesenchyme. It's not where you've come from, it's where you're going to. And it's differentiating towards skeletal muscle. It's incomplete myogenesis, which is why they don't look like total skeletal muscle cells. And they can occur anywhere in your body. And the head and neck is a common place. And so I'm glad you suggested that as a differential diagnosis of a pediatric orbit malignant tumor. But don't forget the metastatic, which would be neuroblastoma. Rhabdomyosarcoma, metastatic neuroblastoma, infantile hemangioma, pediatric orbit tumors. What else have I got here? Oh, what do they look like? Metastatic neuroblastoma. It looks like a rhabdomyosarcoma, doesn't it? It looks like a small round blue cell tumor. The tumor cells are not differentiated, but it's not a vascular tumor. So this is where we get special stains.
How are we going to tell the difference?
Well, they're all small round blue cell tumors, aren't they, Diane?
Yeah, they all look the same to me, Amanda.
What does the team think? How can we tell the difference between that and these ones?
So people are saying immunohistochemistry. I think I got it. There's another way too that's helpful. Sometimes the immunohistochemistry can be difficult. So if the immunohistochemistry fails, what else is really useful, team? EM, probably in the old days we might have do EM, but what do we do now?
We did applied these techniques. Yeah.
Fish genetics, they've all got characteristic mutations.
So neuroblastoma has a 1P and MYC mutations, whereas these types of alveolar rhabdomyosarcoma has translocation, so they have tumor-specific genetics. So that's where we'd go these days.
Yeah.
All right. Pediatric orbit tumor, these are very common. So infantile hemangioma, there's a special stain that can identify infantile hemangioma.
Yes, there is. Isn't it?
There is, and it marks.
So it's important for a reason to do with prognosis of these, isn't it, Amanda?
Yeah, and their type of origin. In fact, when I was working in Singapore, we used to get all these random tumors from people who'd smuggle them in their suitcases. They come from Indonesia, where they didn't have any pathology services, and I diagnosed the case of one of these. But in Indonesia, they had excised it, and they thought that it was, because it was a rapidly growing bad tumor, they thought it was something like a rhabdomyosarcoma. But it was an infantile hemangioma. They were going to give the child some terrible chemotherapy, but there's no need because it was an infantile hemangioma. These occur in very young children, less than the age of 2, and they are marked by a special marker called GLUT1. And it's thought that...
Yeah, carry on. Yeah.
And these days we treat them with, what do we treat them with? Drugs, easy drugs.
I think. Is that right?
Propranolol. Yes. GLUT1 is a special stain nition, and it stains the endothelium of these hemangiomas and no other sort of hemangioma at all.
And it is IHC.
It is IHC, sorry, yes. Okay, so coming to the end of my talk. Now, learning outcomes, people generally ignore them, but I would suggest these are important because each one of these, we've been through the lecture, what you're going to do afterwards is you write down the answers to all of these questions. So these are short answer question headers, for example. You can make each one of these into a short answer question. And so you will list histologic high risk factors. You will list histopathology of that. you will describe how to send a specimen to, and you will list the information to communicate to a pathologist. So perfect short answer, question, prompts, and headings. Right, all done. Right. Now let's apply what we've learned.
Yes, so we're going to speed up a bit now. We did the first 2 slides quite slowly while you got used to things, but we are going to go a bit faster now. So let's have a look at what's next on our schedule. Right,
and
3 slides to do. We're a bit behind time.
Oh, so Diane, I put in that the third slide rather than the last slide because the middle slide there is more common in children, whereas the last one is more common in adults. So we only need to do 2 of them, the first 2.
Okay, so let's do these first 2 slides, and then if we run out of time before Michelle, we'll give Michelle 2 to 3, and then we can continue after 3 if we're really keen and still need to go through some orbital tumors. Right, so we're going to have, we're going to come back at 1:15 after you have looked at the things there.
Yeah, in our breakout rooms.
Breakout room.
The first one is a Path Presenter slide. So I hope that you have made an account for yourself in Path Presenter. So Luke, you need to be looking in the Google Classroom. It's not a Word doc. It's the course outline, which is a live Google Doc. It's live. If you've downloaded and saved the Word doc, then you need to look at the live one.
Good, great. You've popped their thing up there. That's great.
Yep.
All right, I'm gonna go head out now.
Yep, let's do it.
Hi, Diane. It was just cut off, so I've rejoined.
All right, I'll put you in the room.
Thank you.
Hopefully I can do that. Assign to room. Right, I'm gonna put you in room 8.
Okay, thanks.
Assign to room 8. Off you go.
Thanks.
Were we all brought back into the
so yes, I did close the rooms.
Okay.
But people are probably everyone else will be back in 20 seconds. But I only gave you a short time with that one.
Yeah, it was really quick.
Yep.
Yeah, we had difficulty identifying rosettes and looking at the actual invasion of the other structures.
Yeah. Okay, so that was a relatively short time with that one.
Okay.
But there were
people were pretty good with this.
Yeah, they were pretty good. Yeah, they were definitely very good. All right, should I'll
you drive and
I'll drive and you talk.
Where did my chat go? Yep, that's all good. Type into the chat questions that arose, please. What did I notice? So what we'd like to look at, Diane, would be the optic nerve head and the choroid.
Okay, let's share this. Oh, come on, share screen, share screen.
And any other questions that arose in your groups, type them into there. Oh, and rosettes. Oh, right. There are tons of rosettes.
Right, so at low power, this seems to me to be pretty straightforward. Did everyone spot the vitreous seeding at low power?
Oh, it's better show us. Just drag that mouse over the top. There we go. It's got that vascular sleeve pattern.
Yeah, yeah.
And the rosettes.
Rosettes. So we go looking for rosettes. So there's lots of like
some
pseudo
right
rosettes out there around the blood vessels here,
but there's proper rosettes too. There's some.
So these are homerite rosettes. They don't have a hole.
Yeah.
Yep, and then you can see them. So they're quite spotty, aren't they? They're just mainly in this patch here. But you can see them here as definite rings without anything in the middle.
Homerite rosettes. Good.
All right. Choroidal invasion.
Choroidal invasion.
All right. So the way to spot choroidal invasion is to go whiz along the Brooks membrane.
The
RPE. The RPE. Yeah. Whiz along the RPE. So here, look what's happened here.
Yeah. Yeah. But probably because it's broken here and it's lost, isn't it?
Broken, yeah. So present, but not.
Probably not more than 3 millimeters.
No.
Yeah. So choroidal invasion.
Here's a better bit, right? Because here's over the top. Yeah.
And there, see the little group underneath there. Yep, absolutely. And then the optic nerve head. Some suspicious things happening there.
Okay.
The head.
Optic nerve coming around here. Okay.
Yeah, and then like just below that, there around that vessel, the central retinal artery and vein. It looks like there's lots of cells in there, around there.
Yeah. This is the laminar though, isn't it?
That's a laminar. But there's 3 levels of what we talk about, isn't there? There's pre-laminar, laminar, and post-laminar optic nerve invasion. And you should always comment on the optic nerve.
I reckon those little cells are going into this glial tissue here in the optic nerve.
I think there's pre-laminar optic nerve invasion. I agree.
Yep. Yep. Okay, and then we've got tumor around here. So any other places we want to look at, Amanda?
So that covers the prognostic factors, doesn't it? ACN, anterior choroid and optic nerve head. So Alex, those are all microscopic features.
Anterior was normal, wasn't it? It's just
anterior. Oh, why does the lens look like that? Is that normal?
So no, it looks a bit squished, doesn't it?
Like a UFO. I don't know. It's a child. It shouldn't have a cataract. So
no,
probably processing artifact.
I think it probably is. Yeah.
Okay.
So if you get retinoblastoma in your practical, yay, good.
ACN.
Yep. And you'll be able to spot the other things like the thing. Yeah. One thing that is often really difficult is whether or not there's 1 or 2 tumors present. I find that quite hard.
Yes.
It's metastasized all like this. It's really hard. What's your tips for that, Amanda?
Does it matter? Like, is it multifocal or unifocal was the question you're asking?
Yeah.
The answer is I would do genetics and not worry about that.
Yeah, I would do. Yeah. So I don't think that's important.
Is there any calcification?
I couldn't actually see any. It looks really, really dark purple calcification and kind of shatters. There might be a little tiny bit of early calcification in here.
It wasn't prominent.
No, there's a nuclei. Yeah. No, can't see any.
And the light pink areas, is that necrosis?
Yep.
Yep.
All this is necrosis.
Oh, this has got a great example of the vascular sleeve pattern. What's that? Vascular sleeves.
Yeah, so the cells only survive where they can get oxygen, and they get oxygen from around the vessels. So the oxygen goes out here and then stops, and the rest of the tumor necroses.
So you can see it's got a diffusion radius. Does the distance of the vitreous seeding matter?
No.
Yeah. So ACN matters.
Okay.
Does it matter if there's necrosis or no necrosis? No. No. Doesn't matter. Okay.
Should we look at number 2?
Let's. which is, I hope this works. It's a RCPA sectra slide.
Okay, so I will put you back. I'll put you in the same groups. Here we go.
And this is located on the Google document.
Yep. Okay, so we're coming back to the main session here. That's good.
Do we need another breakout? Oh, we've
all been brought back.
Oh, sweet.
Yeah. So everyone will join us in about 10 seconds. Okay, so everyone's back here. So some of the things, Amanda, that I was talking to people in groups about was, how do you tell the difference between a lymphangioma and a hemangioma? And I was suggesting the very, very simplest thing is the presence of red cells in many of the spaces will probably be a really good clue. And how do we tell the difference between infantile hemangiomas and other hemangiomas? And my answer was, we do a GLUT1 stain.
And we pay attention to the age of the patient too.
All right, and so yes, that's right. Bobak was asking, was there any encapsulation in this specimen? So it was circumscribed, but not encapsulated.
I would say circumscribed.
Yeah.
Because it didn't have a thick fibrous capsule. So fibrous capsule is what I think of encapsulated, but circumscribed is a better word for drawing a pencil line around the outside.
Okay, I'll share and then people can ask more questions. I think it was a nice straightforward one actually. If people would like to start typing questions, that would be great, and I will pop into the thing.
Because I think I remember I submitted this one to the QAP program many years ago, and now I've recycled it again. Isn't that marvelous?
It is. It's really good. Yeah. Here we go. I will click on that one.
Do we use the same systematic approach for anything, Alex? So we describe if there's any normal tissue, then we describe the pathology, low power, high power, and any prognostic factors.
So
is there a differential diagnosis?
Is yes, we do. Yeah. Okay, I'm just going to share the screen here.
Yep, and then we'll answer those questions. They're good questions because this is a bit out of it's not a solid tumour, which is everything else that we've looked at has been a solid tumour. So this is a bit different. So
you can see some other people looking at it.
Yes, isn't that cool? It's like a Google document.
Cool. We can see who's looking at it live here. All right.
You're all anonymous.
All right, what was the tissue between the vascular loops? To all this stuff here. What's all this stuff here?
In fact, would you call them vascular loops, Diane?
I wouldn't. I'd call them vessels. So we can see vessels here with red cells in. But yes, all this stuff here. They look like these cells to me.
It's kind of like back-to-back vessels and probably some pericytes and stromal cells.
Yeah, sheets of endothelial cells, Nisha's written. Tumor cells, Bobek's written. Yes, they are. So these are also endothelial cells that haven't quite developed lumens yet.
Yeah, but they will be arranged in congeries of vessels rather than growing as a sheet. They are still arranged. It's the vessel, the lumen hasn't developed, but they're developing like that. So it's vessels with solid lumens.
Yeah, tubes without the tube. Yeah, right. Any other questions about this one?
Cores sort of thing. Can you tell where the location of the tissue would come from, Diane?
All right, so it's a bit tricky, but let's have a look around here. So if we go out,
would you look?
Go to the edge. If we go to the edge, it's kind of like nondescript soft tissue, really, isn't it? So I can see it's coming from soft tissue. I would only know this came from orbit if I was told.
Yep. So soft tissue mass is location. All good?
All good.
Okay. Yeah. How are we going with our time?
We're behind as usual.
Okay. That's all right. That's all right. So we don't need to do the third one because we've covered vascular things.
Yeah. So how are we? Gallery view. Is Michelle joined us yet?
Can we? I'll just participants.
Yes, Michelle is here.
Oh, you're called Michelle. Good to hear you there. Would you like to turn on your camera?
There you are.
Hello.
Hi.
I didn't make it into work, but I can see.
Yes. No, I'm in work.
Yeah, you're at work. Yes. So we have a choice now. Should we do the genetics and then do the orbit tumors next? I think that might be quite good, actually.
Yeah, we'll have a bit of a break from looking at.
Yeah, I'm happy to go whenever anyone wants to go.
All right. Should we get you to go, Michelle, and then we'll do the orbit tumors? Oh, what was the third specimen out of interest? People are saying.
That is a cavernous hemangioma, which is another vascular tumor, but it's not common in children, mainly in middle-aged adults.